they don't teach medical English too much, so we must
Yes.
try to learn ourselves.
Yeah. That reason why I appreciate that. Mean like many students share with me about that thing. Like they cannot find a good environment for studying medical English, and they really want to improve, but they cannot don't have any environment to do it. That reason why when you can join here, I am so happy to have you today. That's really nice.
Thank you.
Yes. Hello, Miss Hang. Nice to
Hey,
see you. Yes. And we still have the new member here, is Mr. Nguyen or Nguyen. I don't know. I don't know. Can you tell me about yourself?
myself.
Yes, sir. Miss Nguyen.
Uh,
Hello.
hello,
Yeah.
hello, hello.
Yeah.
Yeah. Hi,
Yeah.
everyone. I'm Nguyễn Thuong. I'm a lecturer in pharmacy and medical university in Ho Chi Minh. Uh, Now I'm a PT student in Hiroshima University, Japan.
Yeah.
And because of my English is not good, so I'm really want to join with yeah, with us.
Yes.
Mm,
We're here to talk and to
mm,
improve our English skills. So don't worry about this. We will
yeah,
work together.
yeah.
Okay. Thank you, Anh Hoàng. How about Hoa? I don't know who you are. Hello.
Yeah,
Oh,
hello.
yes, Miss Hoa.
Yeah.
Okay. Can you open your camera? Is it convenient for you?
I think I'm scared and shy,
Okay.
so I don't want to open video.
Yeah, okay. It's okay. Okay, so can you tell me to us about a little bit about yourself?
Yeah, I'm a doctor and I'm working in Cần Thơ, oncology hospital. Yeah.
You're a doctor. What's your
Yeah.
specialty?
Mm, my specialty about nutrition.
Nutrition. Oh, nutrition doctor.
Nutrition.
Wow, that's really
Okay.
nice. Yeah. So where are you working now?
I'm working in Cần Thơ Oncology Hospital.
Oh, very nice. Yeah, now we have the new province join our club here. That's really nice.
Yeah.
Nice to see you here. Okay, don't
Yeah.
worry. We're here to improve about the medical English speaking, and don't be shy. Just free to talk. And yeah. Hello, Vâng.
Yeah.
Nice to see you again. Yeah, Vâng is a very old member. Okay, so I think here today is easy. Enough for a start, and if have someone who want to join, it's okay. Now we can start our talk. So today we will talk about pancreatic cancer. When I choose this topic, I still feel like actually I want to do about a series of cancer for our talk. The reason why we did many cancer before, but so now I'm consider what should I choose. I consider between GI tract cancer and what else about prostate cancer. But from my knowledge, I think I'm confident with the pancreatic cancer. Even Mr. Leon tell me like, wow, it's a very difficult field. How can you choose it? Yeah, is it true? Is it true? Is it difficult, right? But actually, in here today we should talk about something like something we know about the general knowledge. We will not go into very detail about the treatment or about some related problems. So try to make it easiest. Okay. Okay. So now we come to our talk, and let's start with the something. Yes, we have the new case. So before I start a new case, so anyone can tell me about how you know about this the cancer or how the possibility or some kind of information related to the cancer, even in Vietnam or even in another country, some kind of any sharing about this? And Hoàng, how about, as I know in some Asian country have some the number of the patient with the GI cancer is higher than in another country. Is it correct? No. So how is it based on your work of field? Yeah.
Yeah, it's very difficult to talk about all of the cancer because when we talk about the cancer, it not mean that one disease. It means that's about more than 300 different disease, and with each cancer, they have the many characteristics different between another. So when we talk about the cancer, maybe we have to think about one cancer. So I don't know how to
I
say
mean,
it.
like I'm asking about the GI tract cancer. I mean,
GI tract cancer.
Yes.
Yeah, as my opinions, GI tract cancer. I know in on of the GI tract, we had many cancer from the mouth and esophagus and gastric and intestinal.
Yes, I agree.
Yeah. And as my opinions, the more upper cancer like
Upper GI
mouth,
tract cancer.
Yeah,
Upper GI
yeah.
tract.
It's more aggressive.
Aggressive.
More aggressive.
Yes.
For example, the colon cancer is common cancer, but it's easy to treat than the esophagus cancer.
Yeah. I agree too.
It's
yes. Okay, thank you so much. Because as I know, I have some information about like some gastric cancer or what we call liver cancer in the epidemiology in Asia. I mean, for Asian people, they is higher than in other country. They explain because of we have the different diets, and maybe our diet have something like food, maybe spicy food, or I don't know what happened in there, or some food like we call this a poison food. Poisoning food. That reason why in Asian they have the higher the risk of get the breast cancer. I'm talking about the not pancreatic. I will not come to about pancreatic now. Just like about the gastric liver cancer. Yeah, they get the number of the patient like this. Okay, so we come to the topic today. Sorry.
We have now we have the nutrient doctor here, so I think this is very useful for me to learn more about the nutrient related with the liver or gastric or GI cancer.
Yeah, that's really nice when we can have many people, doctor from some kind of the faculty.
Yeah.
Okay, so can we start let's start this question. The first question. Anyone can help me to read that question? Okay, I'll go. Let's start with Long. Yeah.
Yes. Okay.
Yeah, go ahead.
A 64 years old man comes to physician because of 2 week history of intermittent epigastric discomfort. He reports that his urine has been very dark and his throat has been pale for the past week. His appetite has decreased and he has had a 4.5 kilogram, about 10 pound weight loss during this period. He has smoked 1 pack of cigarettes daily for 30 years. He drinks a few shots of vodka daily. He has no history of severe illness. He has chronic left knee pain, for which he takes acetaminophen. Vital signs are within normal limits. examination show jaundice of the skin and scleral exteriors. There are scratch marks on the extremities. Abdominal examination show a non-tender paper mass in the right upper quadrant. The reminders of the examination is normal. Laboratory studies show ultrasonography show delayed hepatic and pancreatic ducts and a distended gallbladder, which
Gallbladder.
which of the following is the most likely cause of the finding?
Okay, so I'll start from you first. Based on those information from this question, so what you can can suggest about something in your mind about the disease patient have? What abnormal here? Yeah, just go with that. Long?
The first thing is that the chief complaint he has 2 week history of intermittent epigastric discomfort.
Discomfort. Yep. Okay. Anything else? Okay, I think signals have problems. Okay, Hoa, how about Hoa? How you think?
In the examination, he has no dye of the skin and scleral exteriors.
Okay.
And a scratch mark on the extremity. I think it is because he had a itchy.
Okay, itchy. Yeah. Okay. Anything else, Hoa? How you think? Yeah. Thank you, Long.
Yeah, I lost something.
Weight loss.
Yeah.
So what you
Yeah,
think when patient? Again, I cannot hear you well. Have something problem with signal, right? You guys, can you hear me clearly? So no,
Okay.
the signal have problem, right? Okay, hello, can you hear me? Yeah.
Yes, I can hear you.
Yes, how about Hoa? I think the signal from Hoa, right? I cannot hear
Yes,
her.
I can hear her.
You can?
Sorry, I cannot hear her.
Oh yeah. Okay. Sorry. Okay, Hoa, can you tell me again what you are trying to say? Okay. Any idea for that? How about Vâng?
Okay. Let me see. I think that one important point is the abdominal examination. A non-tender palp, a mass in the right upper quadrant.
Mass?
Yeah, and some index in the laboratory studies. Especially the bilirubin. Both the total and direct bilirubin are abnormal. And the ultrasonography also have some problem here. The extrahepatic and the pancreatic duct is dilated, and the gallbladder is distended.
Distended. Okay, a lot of things. So how can we divide this into symptoms? Like what's the group of symptoms suggest that another one have the problem here? So let's start with the clinical examination first. Patient comes to see us with the epigastric discomfort, right? So now they see the patient have the urine is dark and the stone is pale. What the meaning of that? What the meaning of urine is dark and the stone is pale?
Well, in my opinion, I think that there may um, there are two ways to cause this situation. Firstly, there's something that block the dot in outside the dot, but it are pressed on the dot. So you know what?
I don't
Okay.
understand.
How can I express my idea? Okay.
What the problem?
mean
Yeah.
obstruction?
Yes. Yeah, the
The word
obstruction.
obstruction.
Yeah, obstruction. They have the
Okay,
obstruction
obstruction.
here. Then it's the extra hepatic. Okay, this obstruction is something outside the hepatic.
Yeah, outside and inside the dot.
Yeah. And what the next? Patient decrease appetite and weight loss. What the meaning of that? We suggest something. How? Okay, here we have one. It's very easy.
Yeah, she have appetite decrease and weight loss. It means that decrease the absorption in the gastrointestinal tract. I think about the cholestasis.
Cholestasis.
Yeah,
Mm.
because also he or she increase the direct bilirubin. Yeah. So that's the reason why he has the dark urine and the pale stool.
Okay, but what about the weight loss in 2 weeks? 2 weeks weight loss.
Yeah.
Really fast. I wish I can lose weight.
Very fast. It's kind of unreasonable. It made me think about malignancy or something like that because he is 64 and yeah. So you should think about malignancy here.
Yeah, we call like systemic symptoms for in case we suspected have the cancer. We call cancerous symptoms. Okay.
Yeah.
And the patient here, they have the what else? I will let the past medical history about the smoking here because we will discuss about it later, and the drinking too. So we do patient have the acetaminophen. I think it's not related to this case much, and the patient have the jaundice, skin and scleral interest. And one more thing, the patient has scratch marks on the extremities. So what the meaning of these two? Scratch marks. They do something, yeah. He do something on his extremity. So what the meaning of that? What do we hear? We say. Hello.
Okay. Can you?
Yes. Where are you? Can you understand my question? I asked about the scratch. What the meaning of that? Like he tried to do something on his extremities. So what the meaning of that?
It's related to the bilirubin, right? It's like a nerve or something.
Bilirubin. Any idea about that?
Scratch mark on the extremity, upper extremity or something. In Vietnam, they call ngộ độc đầu tất cung của dây thần kinh. Có phải? Is that right? I don't know. Yes. It's like the effects of the bilirubin, right?
Well, stretch mark.
Scratch mark.
Yes,
like yes, in Vietnam they say like khi bị nhăn ngứa, so they scratch it, right? I don't know.
He's talking Vietnamese English. I cannot understand.
I mean, when it gets itchy, they scratch. That makes sense.
Sorry, I can.
Mr. Long, can you say?
So it means that he's itchy and it's the symptoms of pruritus, right?
Pruritus. Yeah, pruritus. And yeah, that's it also have the name like pruritus. And this means like have the accumulation of the serum of the bile acid, and the accumulation because obstruction. And this happen in patients have the obstruction in the place have related to the like biliary, and this make the pruritus. Okay, and all this. So now we come to our choice here. What do you think, patient? Oh, sorry, I forgot a little bit about the mass. We do the abdominal examination, and we see the mass on the right upper quadrant, so we can location some the organs in there, and we can see the mass. So let's see. And here we have the lab test. So based on lab test, what you can read from that? Who is Anh Hoàng? Lab test. You can read what you can read from that.
It's here we have the ultrasonography, and we saw the dilated extrahepatic and pancreatic duct, and this time the gallbladder is mean that it just mean that he has the obstructions in the bile duct. Yeah, but I don't see anything about the mass. It's not. Is it a tumor or not tumor? Just
like
say
they do
that.
examination, like the abdominal examination, like
But
see the mass.
in ultrasound, they don't show the property of the mass. Yeah. So in this this ultrasound result, we just say that there are obstructions in the bile duct. Yeah,
obstructions
just
by okay.
and maybe the position of the obstruction is about the main duct.
Yeah, so we do examination, and now I just which and I want to introduce the concept. I think you guys need to know about this. Have you ever know about this? Courvoisier. Sorry, anyone know about this before? Sometimes we call it psi, or it's equal with the Lauren. Yes, we call like Courvoisier, psi, or the law. And they usually do that examination for this patient have some problem in the bile duct, or even this belong to obstruction or some kind of thing. Here we suspect it have problems, and they will do the examination. So first we need to know what kind of examination, and second we need to know how to do it. Like for our doctor or even this student, they can do it in the hospital too. So anyone know about this? And Leon, do you usually do it in the hospital in there?
When we palpate the abdomen, we do palpate the upper quadrant, the right upper quadrant, and yes, I don't see this sign very much. It's not very common. Technically, this sign just tell me that okay, something make the gallbladder enlarge. The gallbladder becomes
correct. Something make the gallbladder enlarge. Then that's the reason we do that things. That's test. We call that a sign. And this is suggest when we think the patient have like patient have the painless jaundice and that palpable gallbladder, that we do that examination to confirm again what's happened, and we can assume like have obstruction in the bile duct, or even this pancreatic or some malignancy there. So they do that. Also we know about the ambulatory router. The router, like the place how they can come the common duct and the pancreatic duct go together in the duodenum, and that's play too. And then what they want to is there, they want to check is there any abnormal there, and they do this a Courvoisier style or Courvoisier law. You guys can check about this. And here in this case, they did it, and went to exam have any problem in there. Okay, so now we come to the option. We have
Sorry.
Yeah.
Courvoisier sign is that điểm túi mật in Vietnam, right?
Again?
Điểm túi mật. And điểm
No,
túi
it's
mật.
not Murphy sign. It's not Murphy sign.
Oh, okay.
Yeah, we have the other name Murphy sign. This is different. But in general, when you do the test, like the exam, like it's a little bit different, but the place is the same, but different about the how we do it. So you guys can compare between the Murphy sign and the Courvoisier sign, how different when we do the test. It's a little bit different. Yeah. Anyone not tell me? Yeah.
Murphy sign is when you have pain.
Yes.
Yes.
Your sign.
Yes.
You don't really need pain with that.
Yeah.
So patient usually painless. And one golden rule in cancer is usually painless.
Yes, correct.
So if you have cancer, you probably don't have pain. If you have pain, then I'm not worried about it.
Sorry.
Yeah, this is a painless because the painless
No,
jaundice.
it's a very good question.
Yes.
Very good.
Yeah. So, okay, clear. Courvoisier sign for the painless jaundice and palpable gallbladder. For the Murphy sign, it's a pain. Yeah, this is painful. What's a painful? Some like infection or some like inflammation in there. It can make it painful. So here we have some option. They ask us about what kind of cause. Just ask about the cause, and in this patient. And actually, the patient still have the past what we call like past medical medical history. This is smoking and this is alcohol drinking. Yeah, drinking alcohol and smoking. So what do you think about this case? Any idea for that? Nguyen, how you think?
I think that this patient have a very typical symptoms of cholestasis, and that's the reason why I don't think about the F and the A. For the labs, we need to kind of differentiate for acetaminophen-induced liver injuries. She has a history of using NSAID, but it's not kind of too much until we have toxic to the liver. And also in the test we do not mention to the transaminase. So I assume that it's normal or it's just nearly normal, right? So I don't think too much about acetaminophen liver injuries. About the primary sclerosing
cholangitis. Yeah, cholangitis.
So it is a kind of the obstruction in the bile duct, but it happens from both inside and outside of the liver. So it means that we need to, if it has, we will see the enlarge of the bile duct both inside and outside of the liver. But yeah, it's not suitable here, right?
What else do you see with that? There's one more lab, actually two lab you see with PSC, and also with acetaminophen. That's telling you that is not the liver. Can you scroll up to the lab?
Please go up to the previous. Yeah.
What? There's two missing lab value that tell you right off the bat that is not a liver problem.
Yes. Nguyen, how do you think? Which is?
It's it's not a liver. You mean that's the two lab tests?
The two lab value that missing in the table that telling you that this is not a lab problem. This is not a liver problem. So you can rule out acetaminophen and
Yes.
primary sclerosing cholangitis.
The ALT, right?
Increase the alkaline phosphatase.
No.
Start with an A. They all start with an A, by the way.
Yes. Who knows? Who knows? Very interesting question. Yeah. I will remind the question again. So in the lab test, which the value make you think the patient have the liver problem or not? Like when you see that's a value, you can rule out that the patient don't have the liver injury or some kind of. He will have the option like acetaminophen induce the liver injury. So which is?
It's the ALT.
Is ure dichordia.
Who say? Again?
Is ure dichordia.
Urine nitrogen.
Ure dichordia.
No.
Yes.
No, it's not.
It's ALT. Right?
Yeah, ALT and AST. Yes, correct.
STALT. We also call it liver enzyme.
Yeah, liver enzyme. So, Mr. Leon, how we can see in the patient have the acetaminophen-induced liver injury with the lab test?
Whenever you have liver injury, this value will be raised. So because we don't see it here, probably not acetaminophen.
Yes.
Actually, I just mentioned that she have no. We have no the transaminase test here, so we assume that it's normal, right? AST, and ALT, right?
Yeah, it will be
Transaminase.
present here. It will be present here, and especially like for the patient have like a drug-induced liver injury, the level of the liver enzyme extremely high, over than 1,000 UI, over than 1,000. You should remember that. For another cause like a virus or some. These different cause like alcohol, maybe the liver enzyme is not look like very high like this, but for the drug-induced injury, it's extremely high, and that's have you suspected the patient have the drug-induced liver injury? Yeah.
Now another question for what with alcohol. What value is higher? What liver enzyme is higher in alcohol?
There has presented after GGP, right?
GGP increased and AST over than ALT double. I mean,
Double
the rate.
value.
Yeah,
AST.
double value. Yeah, the
We
rate.
usually make a joke in America that if you drink alcohol, you toast it. The last 3 words of toasted is AST, so that's how I remember it. We toast it when we drink alcohol.
Okay, so again, we come back again. We cannot. So what we choose when you rule out all this? So what is your final answer?
My final answer is B.
Malignant biliary tract obstruction.
Yeah.
So anyone have a different idea?
I think. How could you say it is that a malignancy, biliary tract obstruction? How can we know it? It's just a tumor. It can be malignant, right?
Actually, how we asked about the most likely, we say like we didn't get a confirmed test yet. Most likely mean like what you think in your mind, and then it can drive you to do another test to confirm this is malignant or not. Like here we suspect what the most thing you make you is in your mind now.
Yes, but we also have the ultrasound, right? So why we don't we describe
Okay,
about
so why I
that
think that
sure?
patient have the high risk for the malignant. And first you're looking for about you see about the age of patient. Patient is 64 years old, and patient have some systemic symptom here, like weight loss or some like. And patient also have the past medical history with the what we call like this is called smoking. One bag of cigarette daily for 30 years is also high. And another thing, patient also drink alcohol, shots of vodka daily. You see, daily is like a lot. It's not look like a very short term or some kind of this. And you see the symptoms too for this age, but those of symptoms is a highly suspected patient have the malignant risk factor, or malignant problem or some kind of that.
Yes.
Yeah, I think I
Uh,
have the one more reason to think about the malignant in this case.
Mm-hmm.
Actually, in one of the medical histories, the clinical finding and the ultrasound, one of them make me think about the obstruction in by chart only about this. And in clinical finding, we can see the mass in the upper the mass in the right upper quadrant.
Yeah, mass right
Yeah.
upper quadrant.
Yeah, but on of them just make me think about the problem in the abdominal, make the bile duct have the stop. Yeah, but why we have to think about the malignant in this case? Because in this case, most of the make me think about the mass, and this is a benign or malignant. But in this case, we have to think malignant first, because if we think about the malignant first, we have to do the next step to make to get the clinic
histology. You mean like histology?
Yeah.
Yes.
Another exam to make sure that it's not malignant first before we think of another other disease.
Okay. Yeah, I agree.
This is the reason. This is the reason why in this case we have to think about the malignant first. After that, in other disease.
Yeah. Okay.
So, yes, the ultrasound just showed us like dilated extrahepatic and pancreatic ducts, right? So, what is the patient has the pseudomass in the head of pseudomass like in the head of the pancreas. Yes, it's.
You mean like the complication of the chronic pancreatitis, right?
No, it's not pain.
Yes,
yeah,
of course.
It's not chronic pain. It's like a pseudomass. Yes. Yeah. So the patient has also dilated extrahepatics and pancreatic duct. Yeah. So and next step we
pseudomass. Okay, I will say something. Pseudomass. Pseudomass.
Yes, I think as I say, we can think about many disease in this case, but we have to think about the malignant first. It doesn't mean that we don't think about another disease, but we have to think about the malignant first. After we have the more evidence to make sure that it's not malignant, we can think about the next disease.
Yeah.
So it's the reason why the question is which following is the most likely.
Yeah, most likely.
It means that we have to think it's first. Yeah, I think so.
I agree with Anh Hoành. Yeah, that's that reason why we say so. We raise about the most concern about the important thing first, and then we can looking for about another thing later. Don't worry. In case we do the wrong diagnosis, we will have to check another thing and to make confirm the diagnosis after that.
Yes, the reason is just like they have just malignancies in here. So what if they had pseudomas in there? So what you gonna choose, right? Yes, the true answer is malignant biliary tract obstruction.
You cannot
right?
explain some symptom here, like a patient have the weight loss significant. You know, like for the weight loss significant, this is a highly suspected malignant process. You should know about this. Yeah, you cannot find any reason can explain about that symptoms. You cannot find any reason like very fast like this. So what make the patient have the weight loss in the short term like this?
Yes. I'm sorry. Yes. First of all, I apologize, press. I talk very much, right?
Those are very good questions.
Yes, I agree.
If the patient has their common bile obstruction, common bile stenosis, so they will have lost appetite, right? So yes, the reason that they have lost appetite and they just like that. I think yes, it can be. So, but if the patient with the other disease, so breast cancer or something like, or sigmoid.
You mean metastasis,
colon
right?
cancer. Yeah.
Yeah, metastasis. Yeah.
Okay, that's a good point. Yeah, the metastasis also can be classified as malignancy. So if it go to the bile duct, which it rarely do, but it can. Cancer can go anywhere they like. This may also cause obstruction. That's why B is the correct answer, but we don't know what type of cancer it is yet. We don't say it's original from the bile duct. We don't say it's original from gallbladder or liver. We just say that's something that may be cancer there. Okay.
Yes.
Reason why A is not correct is the lab value is normal and the patient doesn't have any symptoms that look like it. C also is not correct because the lab value is not there. Also D, cholelithiasis. That's a mouthful. Patient will usually have pain on the right upper quadrant with Murphy sign, stuff like that. But we don't see that as well. Hemolysis, patient hemoglobin is normal. We rule that out. Chronic pancreatitis, usually patient will present with glucose intolerance because, when you have chronic pancreatitis, your pancreas enzyme doesn't
work. Yes.
Like diabetes. Think about diabetes. Patient doesn't have symptoms of diabetes, so we rule out chronic pancreatitis. So we left with B, which is the most reasonable explanation that can explain all the symptoms.
Yes.
Yeah, good question, Pisai.
Yes.